All right, everybody, good afternoon. Seems like it is on. All right, so we are in the Oxygen 101 session. If you are in the right or wrong place, that's where we are. You will enjoy it, even if you think you're in the wrong place. I do have one housekeeping item before we get started. If you are a respiratory therapist, please be sure you have signed into the conference to be able to get your CE credits through the AARC, and the sign-in sheet is at the PFF registration desk at the bottom of the escalators and to the right as you come down. And actually, so you'll go out of these doors, I think, to your left, and the desk will be on the left over there. So if you need to do that, please make sure you do so. I have the pleasure of introducing Susan Jacobs, who's going to be leading off our session today. Susan's a research nurse manager in the Pulmonary Critical Care in Medicine Division at Stanford Health Center. She's also a nurse coordinator in their ILD program, and she has a background that includes roles as a critical care nurse educator, an NIH dyspnea and exercise project director, and pulmonary rehabilitation coordinator. She works closely with the PFF and the LAM Foundation and coordinates ILD and LAM support groups, educational seminars, and webinars. She chairs the Oxygen Special Interest Group for the ATS and is the lead author on the first national patient survey of almost 2,000 supplemental oxygen users in the United States and the ATS Multidisciplinary Oxygen Workshop Proceedings, which were both published in the Annals of the American Thoracic Society. Susan's the recipient of the National LAM Foundation Leader Award, the Outstanding Clinician Award from the California Thoracic Society, and she was recently inducted as a fellow into the American Academy of Nursing. So please help me welcome Susan. You're going to learn so much from her. I do every time she talks about oxygen, so enjoy.
Thank you. Thank you, and I'm just, as always, at the summit. I've been to every summit, by the way, since the first one in 2011. So it gives me great pleasure to see such a huge interest and turnout. We have a challenging topic today, and you know that much better than I. So the goals of today, we are going to go through a bit of understanding what is hypoxemia, which is a low blood oxygen level. We will talk a bit about the prescription of oxygen, how we get that prescription, what documentation, kind of testing, and then we're going to kind of dispel some myths about oxygen. And I will spend roughly about 45 minutes on this, and then I am lucky to be joined by Dylan Becker, who is sitting down here, from Apria, who has very graciously, first of all, come and supported our patients with oxygen at this meeting, and also has some equipment here. And he will talk and show a little show and tell the last half hour, and we'll leave plenty of time for questions, and also you can come up and actually touch the equipment, ask questions, etc. So we really want this to be your session, so we want to make sure that your questions are answered. I may not have all the answers. That's a lot of things we don't have good answers about, but we are certainly working towards that. So when we think about treating the patient with everything, you can see it's really multidimensional. And you can see that we have many things to address, and I think you've certainly gotten some information on disease and diagnosis, some breathlessness, so you've heard about pulmonary rehab, a little bit about cough, again, exercise, how important it is, and we've had a lot about palliative care, symptom management. This is all symptom management. And so this is really the focus of addressing this area, which is a huge issue for interstitial lung disease patients. So what causes low blood oxygen in patients with pulmonary fibrosis? And it can be a combination of things, but the main derangement, the main problem lies in that interstitial space. And you can see that wrong one. You can see we take a breath, it comes down your trachea, and it bifurcates into the large main bronchi, and then it keeps bifurcating and splitting off like a tree, into these alveolar sacs. The alveoli are the working horse of the lung. There's 300 million of them, and they're designed for a very efficient gas exchange. They're very thin-walled. They're surrounded by capillaries, and the blood cells actually march through single file. That's how thin they are. So they're really designed to facilitate oxygen coming into the blood and CO2 going out. So this is the capillary bed, and you can see that's it's really a sheet of blood around the lung, if you can think of it that way. So if we kind of bear down and go into the interstitial space, this is the wall. See the oxygen coming down. This is the alveoli. This is the wall. So the oxygen crosses over into that capillary. So magnified, here we have the oxygen crossing from the alveolus to the capillary. And we call this the alveolar capillary membrane. And normally it's thin. And normally on a CT scan, it's invisible because the scan shows black, which is air. But if something happens to the lung, whether it's an exposure like a pneumonitis or unknown, like idiopathic, anything that causes inflammation or scarring, then we have this interstitial space becoming not a space, but it's an actual density because now it's scar tissue, much like when you cut yourself and develop scar. So this scarring thickens this alveolar capillary membrane, and now, especially with exertion, you have a problem getting oxygen from the air sac into the blood. So on the CT scan, we can see on the first one on the left, this is a normal lung. So it's mainly black because the beams go right through the air, expose the X-ray. But with ILD, you have these densities, and I think you've heard a little bit about the honeycombing, ground glass, inflammation, and this is now, because it's a dense tissue, it shows up on the film. And we call these interstitial markings, and that's what you'll see in the radiology read. So these densities show up, and those are all areas of either fibrosis, scar, or some inflammation, and that's what's preventing the gas exchange. I just have one housekeeping. Nobody started my timer, and that could be really a problem. so let's see. Maybe I'll get you to give me a heads up like at 45 minutes. Okay, thank you. So just want to make sure I didn't skip one there. Okay. So when we go through historically, what data gave us the evidence that oxygen was beneficial, and the actual studies that we still base some of our care on today were done in the early 80s, 1980 and 81, the NOT trial and the MRC trial. These were done in COPD patients, not ILD, so that's chronic obstructive pulmonary disease, so that's really smoking-related lung disease. But these trials really definitively established that there was a survival benefit if you had resting hypoxemia, so that means when you're sitting like this with no oxygen on, that your levels were low, so they were severe. And those patients, when given oxygen prescription for 24 hours a day, they found that if you use it at least 15 hours a day compared to those who did not, there was a survival benefit. So we now prescribe oxygen many times based on this data set, which is really based on COPD and more sick patients at that time. They did repeat one study, again with COPD patients, the LOT study, just a few years ago, and they actually randomized patients with mild to moderate hypoxemia to receive oxygen or not, and there was no difference in survival over time. And this kind of worried some of us in the ILD world. We thought perhaps they would start to apply this same data and say, well, you don't need oxygen, but it's not happened. And I can show you some information that ILD patients are different in terms of their hypoxemia. So we do prescribe oxygen today based on some data from before. Oh, thank you. So what is the benefit? Again, based on some of this data, and we don't have all the data, but we basically know that there's a survival benefit, and I put 88% there, but that's really not quotable. I mean, for Medicare, you can be 88% or below to qualify for oxygen. We generally instruct patients to keep their oxygen levels above 90%. So we do feel that the benefit is related to It can help decrease your breathlessness. It won't take it completely away, but it can help decrease the breathlessness, the stress on the heart, especially the right side of the heart that's trying to pump that blood through the lung blood vessels. Because with low oxygen, you can get constriction of those vessels, and you get right heart failure and pulmonary hypertension. We also give it because we think it can increase your activity level. Of course, it's a little bit of a misnomer when you're dragging a tank around, but certainly we know it allows for higher levels of exercise and keep your oxygen levels at a normal level. Sleep, and especially for patients if you have low oxygen at rest, we know it improves your survival. If you don't use the oxygen, and you do have low oxygen levels, some patients can notice their heart rates go up more quickly with minimal activity. Respiratory rate might go up. Again, we can get this pulmonary hypertension where you have this constriction of the blood vessels in the lung, and then the right side of the heart starts to fail a little bit. What we don't have good data on is if your levels are fine at rest and they only drop when you exercise, we don't know if that short-term episodes of low oxygen, if that affects survival. I mean, that would be another study. It's hard to do those kinds of studies. So that area we don't have as good a data on. But we do know that it does improve exercise capacity and shortness of breath. So I mentioned this before. It's kind of hard to see the difference, but this is, you'll notice here you have a smaller right side of it. This is the right ventricle, right atrium, left ventricle, left. And these are the airways, and the blood vessels come all the way out to the periphery. In pulmonary hypertension, you'll see the right side is bigger because it's distended. It's trying to pump through this constricted, fewer, tapered, skinnier blood vessels. We call this cor pulmonale. And this is what we would do an echo for. So it's a pretty routine. It's in a patient who's had long-standing or even early fibrosis, maybe needs oxygen. It might be part of your workup to rule out pulmonary hypertension to get an echo. So key point, for patients, it's important to use your oxygen as it's prescribed, and it's particularly important for patients who have a low oxygen at rest, or if you drop your levels just by getting up and walking across the room. So that group of patients, it's very important to use your oxygen. For those of you who can move around and you're okay, but until you go to pulmonary rehab or get on an exercise cycle or do really exert yourself, and then it drops, it's not the same. We still want you to use your oxygen to get that activity level up, though, and be able to condition and get strengthening. So how do we prescribe it? I think a lot of you have been through this process. We can measure your oxygen levels either indirectly with an oxygen oximeter, a pulse oximeter. It sends a beam through that capillary and you're under your nail bed and bounces off hemoglobin and spits out a saturation. So we can do that, and in the United States we can do that to order oxygen. In some countries you actually have to do an arterial blood gas, which is the other side, which is a direct measure, not as fun, and then they can get a direct arterial sample and they get a partial pressure of your oxygen. So when you are worked up or evaluated for the need for oxygen, we really want to know three things in three situations. Do you need it when you're sitting quietly? Do you need it when you're sleeping? And do you need it maybe only with exertion? Or do you need it 24 hours a day? And that's what we want you to be really clear about when you start on oxygen, if you do, that you understand when to use it. And you could have three different numbers. Maybe your physician says, nothing at rest, but you've had sleep oximetry where you can sleep overnight with a special oximeter. The home care, the companies can drop one off, and they pick it up the next day, plug it in a computer, and it downloads your saturation for every minute, and it gives us a readout. It spits out a readout of what percent of your night you were under 90%, 88%, 86%, et cetera. And then we have exercise. So you might get three different prescriptions for that each situation. And then there's a fourth situation, which is altitude, which is either, I'm in California, either going to Lake Tahoe or Colorado or in an airplane. So those are all altitude. And if you're kind of a borderline needing oxygen, we might send you for what we call a high altitude simulation test, where they actually fill a big balloon with some low-level oxygen. It'll be like 17, 15%. We're breathing right now, we're all breathing around 21%. So it mimics altitude. So it's not a guessing game. We can actually get some information as how you would do at altitude. But that's sitting. So you can't be running up and down the aisles in the airplane. So that's that's exercise at altitude. So this is actually in our hallway at Stanford. We got a patient, a therapist doing a 6-minute walk. This is a very common measurement that we use to assess oxygen levels with exertion. You've probably also heard it in a number of these clinical trial discussions. The 6-minute walk test it's fairly standardized. It should be with standardized coaching, standardized distance. You're told the same thing. You're told how to walk. And that outcome of distance walked and saturation during your walk are often outcomes for some clinical trials. So, for example, nintedanib and pirfenidone, they looked at, did it change your 6-minute walk? So we also do it clinically just to determine if you need oxygen. And we also use it to monitor how you're progressing or if you're stable. So if you're tested every 3 to 6 months, and when we're concerned about progression, we might order a walk and see how your saturations are with oxygen. It might be the first sign of things changing. And then you can see how they got the prescription here. You were fine on room air, but walking 86%, so then we stop, let you rest, put you on oxygen. You started on 2 liters, you hit 87, stop, let you rest, turn up to 4 liters, walk you again, and this prescription was use 4 liters per minute with exertion. So we went over the prescription a little bit. It's nice for you to have this in writing. It's hard to get all this information. I think whether you're a new patient evaluation, a returning patient, there's a lot of data getting, your pulmonary function tests, your walk tests, your CT scan report. So when you do get a prescription like this, it should be in writing, so you remember what you're supposed to use, how much, and then what type of equipment. Now, here we hit a little bit of a challenge. We would love to prescribe, for example, on our population, and we'll talk about the differences, liquid oxygen or high-flow oxygen. Or maybe we would like a POC, a portable oxygen concentrator that goes up to at least 6 on pulse. But sometimes the durable medical equipment company, we call them DMEs, they may not offer particular models or combinations. So we will try and prescribe what we think is the best match for you, but then the next step is to see if the company can provide that. And different companies offer different combinations, and we'll let Dylan talk to you about that too. And things that meet your needs, very important, that have a piece of equipment that meets your needs, getting out of the house. How often do you have to get out of the house? How many stairs do you have? Do you have joint issues and are unable to lift an e-tank in and out of a car? Those sorts of things we want to know to match the equipment to you. So we try on our end, but then what the DME offers is really more restrictive because we don't always have a perfect choice. But that's the process it should go on. So there's a lot of back and forth sometimes. It doesn't always just happen it gets delivered and it's perfect. Sometimes it's a little back and forth, and you know very well, many of you, I'm sure. Okay. This is what we do on our end. We have to, in order to get an oxygen prescription, we need a CMN, Certificate for Medical Necessity. So that means we have to see you in person. We do the testing. We have to submit to Medicare or your insurer what your saturations were at rest with no oxygen, what they were when you walked with no oxygen, and then what they were when you walked with oxygen. And that has to be done in person within 30 days of seeing the physician or the nurse practitioner or whoever. So if you get a walk test and then you leave and go home, and then we get the walk test and go, oh, this person needs oxygen, and you haven't seen a physician, we have to have you come back, and it's a real pain for you. So the order has to be, and the testing within a month of seeing a clinician. So that's a key point. We should know that, but sometimes it's good for you to know that side too. So we prescribe it. We give them your diagnosis, what we've tried otherwise, that you're stable, that you, despite optimal medical treatment, maybe we've tried steroids, antibiotics, pulmonary rehab. I mean, it's kind of an odd list for Medicare. But we list all that, and we say, despite optimal medical therapy, that you need oxygen at this rate and at this circumstances. And then we have to clarify if a pulse dose or conserving device is okay, and we'll talk about those, and Dylan will also talk about that. And really it's important here, if your needs go up, we have to do this again. So it's really important that we don't have you come back into clinic and say, oh, you know, a month ago I had to go up to 6 liters, and I'm really running out of tanks, and I've called my DME, they won't give me more tanks. Well, that's because they need a new prescription, because now you need 6 liters. And we should have known that. We would want you to tell us that, because something's going on if you went from 2 liters to 6 or 4 to 6. So if your needs go up, we need a new testing and new prescription so that we can get you more equipment. So I'm going to go over these briefly, but we've got the real things up here, and Dylan is the expert, so I will just kind of let you know what they are, and then he'll go through them in more detail. So we've got 3 types. We have oxygen that comes in as compressed gas, and those are the metal cylinders. We have oxygen that comes in concentrators, which means it's concentrating what's in the air and spitting it out through your cannula, either in a big stationary, not big, but stationary concentrator that plugs in the wall and stays at home, or the portable ones that you see that you can take over your arm. And then lastly, we have liquid, which when I way many years back, started in this career, I had liquid all the time, and it was very handy because it's you can super cool down this oxygen into a small canister, and then it turns into gas when it comes out. But you can fit a large amount in a small canister. You can get up to 10 or more liters continuous flow in a portable device. So for our patient population, it was ideal, and this has now become very difficult because it's costly. The DMEs have to make weekly deliveries. They need specialized trucks and equipment and a lot of things. So it is a national issue now that as the foundation is involved, and I'm involved in trying to work with CMS and get some data on why we need mobile patients to get you out of the house, and that liquid would be a great option. So that's a challenge, a big challenge. So the 2 flows, there's continuous flow, which is liters per minute. It comes out continuously, all the time. The stationary concentrators in the home, those are all continuous flow. The portable concentrators and even the tanks can have a regulator put on them that only deliver during inspiration. So that's what we call pulse dose, pulse flow, demand valve. There's many terms. Those are oxygen conserving devices. These are getting into, there's a lot of technology. The way these pulses work, they vary dramatically across equipment. So a pulse dose of 2 on one POC can be different from a pulse dose of 2 on another. So the bottom line is we really want you to test yourself, and you should be tested before you purchase or get one of these and use them, especially with exertion, to make sure that they adequately oxygenate you. You need to trigger the device. And we know our patients with ILD, when they exert themselves, you can get a more rapid, shallow breathing pattern. And it may not trigger that device every time. So the only way you know is by checking oximetry. You know, I'm always pointing to my finger, but there's a lot of autoimmune patients like scleroderma. We also use forehead probes, so I should mention that, because sometimes we don't get an accurate pulse. So that's something to be aware of if you have Raynaud's or cold fingers, because we don't want to have inaccurate readings. So we do sometimes use a forehead probe. So the POC technology varies incredibly across all POCs. I think you've seen, well, you just watching everybody walk by here is like seeing an array of what's available. And tanks, and again, Dylan will go through these. They come in every size and shape. Not every shape, but sizes certainly. Different types. This one's a home fill, which you can fill your own tanks at home, and I'll let Dylan go over that, kind of the pros and cons. The smaller ones in the center, the M6 tanks, obviously those are tiny. They don't last as long, but they're very portable. And unfortunately, our high flow patients, more and more we're seeing E-tanks, which is just really, we've gone backwards. It's very un-user-friendly for our patients. So we're really biased about liquid. This is a patient filling her own. There's we call it the reservoir, the mother tank at home. Patients can fill their own portables and then just refill them as they need it. Sometimes you can refill 2 of them and take them out. And there's some pros and cons to liquid as well, but for high flow patient and portable, it's a good option for high flow patients. So POCs, again, there's lots and lots of sizes, shapes, capacities, but the bottom line is, at least from what I'm aware of it today, the highest continuous flow is 3 liters a minute, and the pulse flow is somewhere between 6 and 9. But those are, 20, 22 pounds, so those are large. They're portable, but they're large and they're heavy. Yeah. I'm going to go over some travel stuff. So how does it work? Basically, I can kind of follow you through here. Follow the air. You're drawing air in from around you, ambient. It comes in through these little filters, or sieves. It comes, and the motor is drawing air in, and then it's going through these, it's a sieve, so it concentrates the oxygen coming in from the room air, and eventually spits out, it's not as high a concentration as like what's coming out on E-tank, and maybe Dylan can talk about the difference, but it's still, it's concentrated oxygen. So there's a few things about POCs in terms of battery life. So the battery will last a shorter amount of time. The more rapid you breathe, the higher setting you use. If you use continuous versus pulse, continuous will use up the battery more quickly. And so the battery lives vary, again, among POCs. And then there's some, you can see the difference in terms of breathing rate. The weight, including extra batteries, adds weight. Warranty, if you order this online, it's tricky. You need to know if that company's going to support you. If you end up with a POC not functioning and you're away, how are you going to get service if you don't have a DME and you just had this shipped to you? So it's a lot of questions to ask, when you're going to order that. First, I would say talk to your clinicians and make sure that that's adequate for you and that's going to last you a while. And then I would make sure of asking what kind of service or replacement they would provide you in the event that it breaks. Same kind of questions here. So 24-hour use. This is a new addition to my slide. This is the first time we came across this, that patients are now being provided a particular brand of POC that's for 24-hour use, including sleep on pulse. So I'll let you comment on that. So our question is, how do you know you're triggering it when you're sleeping? How do you know it's adequately oxygenating you? So I would encourage you to get some overnight oximetry. So check your sats. And this is just, I always put a plug in for the Pulmonary paper. I think it's a great publication. This is an oximeter, an appendant cannula. This is another way of increasing your oxygen supply. So pulse dose, I didn't really mention this, but pulse dose advantage is that it's only delivering oxygen during inspiration. So it's making your tank last longer. So that's the goal of pulse dose, because it's not flowing during exhalation. The other way to optimize is this cannula. You can see, sorry, I keep flipping the wrong one. This is the mustache. It's not quite aesthetically as pleasing. This is the pendant, and it acts as a little oxygen reservoir. So it increases the FiO2 of the inspired percent of oxygen you're getting. So it can actually allow if you needed 6 liters with exertion, maybe you, with this, could use 4, and it would have your tank last longer. So I think this is underutilized. It's not really, lovely, and the pendant actually, many patients, it bothers their ears a bit because it's a little bit heavier, but it certainly can help conserve oxygen for high-flow patients, so it's worth a try. And then we always do try and educate our patients on preventing bloody noses, using non-petroleum products. You're not going to burst into flames, but it is combustible, so we don't want that, especially if you're around anything that's an open flame, just in terms of safety. Tripping and falling on that cords are a challenge. And we actually had to add vaping and e-cigarettes. There was a publication recently on the spark, because they're electric. And there was a smoker who had facial burns because they thought, okay, I'm not lighting a cigarette, but I have, but there's still the potential for fire. So just some safety reminders. So our goal is to take the home out of home oxygen. These are 2 of our patients in the past, and they're just really inspirational in how they've continued to have their active and mobile life using oxygen. I'd like to talk a little bit about travel. We know that down here there's 21%, but when you go up high, there's less oxygen. So if you're going to travel, please let us know a month in advance. please contact the airlines a month in advance. They have forms, requirements, they all differ. Most POCs now are FAA approved for flight. They'll ask you to have 1.5 times the hours of the flight in battery life. So you'll need extra batteries. You may need to rent a POC. Medicare does not pay for travel oxygen. But do check in early and just plan ahead and check with us. A cabin, as I mentioned before, is around 8,000 feet. That's just a general estimate, but it's altitude. And I mentioned these. Yeah. So once you get that prescription, we want you to know what it is. We want you to be tested on the equipment that you are provided. And if it is not adequate, we need to know right away, because once you get into that 5-year contract, especially after 6 months, the first year, and again, I can let Dylan talk about these, it's very challenging to change. So very important to get that equipment figured out, assess, test yourself in the very beginning, and we'll work out problems. Yeah, it's a big adaptation. There's a lot of interest in research on patients that are using oxygen. We recognize more and more the burden and the transition. It's a big change in lifestyle for not just the patient, but the family, the caregiver, everyone's involved. So, Medicare's coverage is very fixed. They're not they're interested in, of course, their dollars and keeping costs down, but we want to keep you out of the hospital also, and active and mobile and outside of the home. So there's a lot of interest in this. This is one publication that just went through an interview with patients who started oxygen, and you can see many of them had very positive things. I'm feeling better, my heart's not pounding, my fingers went back to normal, not totally exhausted. Some patients feel it helps their cough. They'll tell me they can tell when they're desaturating, they tend to cough more, can do more. But others, unmet expectations. I thought I would get back to who I was. I thought my breathlessness would be more resolved. And the worry, this constant planning ahead, worrying about, do I have enough when I leave the house, and that sort of thing. Certainly being self-conscious, having to use heavy cylinders and heavy tanks. So we did a survey, and I just want to highlight some of the results. This came out of the American Thoracic Society Nursing Assembly because we had so many issues of patients about their oxygen. So the purpose was really to look at what patients told us were their problems. And we did an online 20-minute survey. It was posted online. We had 1,926 respondents. You can read there the criteria. Most were female, interestingly. They came from all 50 states. About almost 40% COPD, almost a third ILD, some pulmonary arterial hypertension, a lot of abbreviations here. Alpha-1 antitrypsin disease. LAM is a rare lung disease in young women. It's actually lymphangioliomyomatosis. It's a very long word. And some other. So 43% reported their portable systems limited their activity outside the home frequently or all the time. And 35% reported being very or somewhat unprepared to operate their equipment. You can see the patients in general, over 50% of patients reported problems, and you can see these are the ILD population, so they were right at the top here, but you can see very frequent problems, and these were the highest amount of problems. The top one, which surprised us, was equipment not working. I mean, we were very surprised to hear that. And then you can see in descending order, travel oxygen problems, delivery, lack of portables I can manage, other, lack of high flow, not enough tanks for activity outside the home, can't change companies, company doesn't respond to calls, incorrect or delayed physician orders, can't mix systems, like you can't get an E-tank and then also a POC, can't get liquid, et cetera there. And the average patient reported almost 4 of those problems each, so it wasn't just one. How many hours did you want your oxygen to last when you left the home? So the red is how long it did last. So 11% had only an hour or less. Almost 40% only had 2 hours of portable oxygen. And what they wanted was up to 4 hours, and 66% of patients wanted 5 or 6 hours of portable oxygen. I mean, you guys have life to live out there. So this was a real eye-opener of the needs not being met. So I'm not going to read all these, but I just want to let you know how much of an interest there is in this area now in terms of quality of life, survival, morbidity. This is all publications. Impact of carrying supplemental oxygen on exercise capacity. Oxygen therapy for ILD, a mismatch between patient expectation and experience. Oxygen for ILD, a systematic review. This went over every study done. So it's a long list, and it continues. So there's a lot of people interested in improving this situation. So know your prescription. Bring your portable oxygen equipment to your appointments so that we can see what you're using and make sure it's adequate, and we can retest you on it. And you should also be able to test yourself. I mean, I forgot to emphasize that. We really want this self-management. You know what you usually need. You know that when you usually exercise, you usually need 2 or 3. So alert us when that changes and you're needing more and more. So you can do your own exercise tests, whether you're walking around the block, going to pulmonary rehab, going to the gym, whatever you're doing, check your sats while you're doing it, kind of after a while, so you're really at peak exercise. Don't wait, go sit down on the couch and then check it, because that's not giving us the accurate information. So know your saturations, bring your equipment to clinic. It's very challenging to get all this knowledge. I mean, patients, you know, we don't understand all this. Our physicians don't understand. It's a lot of information. I'm going to put a plug-in for the PFF. This is on their website. Oxygen, it's a great booklet. They also have an oxygen information line. You can call up. I don't have the number, but it's in here. If you have a question or a problem, you can call them as a resource. So I just want to make sure I mention that. Demand education. We're not getting education. Actually, I can show you some of that. Maybe I didn't include that. But in our survey, over 60% of the patients got their education from the truck driver. So we realize that's not what we want as healthcare professionals to be going on. But actually, I mean, I'll tell you though, in defense, I have many patients that will say to me they're like their lifeline. And some of them really connect with their delivery person. Others, it's not quite a smooth relationship. So, okay, let's go through some myths. And again, you'll have plenty of time to ask questions. So I'll get addicted to oxygen once I start using it, so I'm going to use as little as possible or put it off. No. So no. So your cells use what they need. You don't need more and more unless your lung disease progresses. And then, yes, you will need more and more. But it's not because of an addiction where the body builds up a resistance. Like some narcotics, you do need more and more. You do build up like a resistance. And might need more to control pain or something. This is not the same with oxygen. Yeah, is it warm in here? A little bit warm? Okay, maybe we can just open a door. Yeah, I feel like it's warm. I see some people fanning themselves. Okay, next. Once I start using oxygen, I'll continue to need more. Maybe, but not necessarily. So it just depends, again, on your disease. And you've seen graphs now. You've seen lots of data with our antifibrotics. And we are seeing this in the clinic. We are seeing patients cruising along in a more stable state. So this is great news for our community. So we have some drugs that kind of slow that progression. So I think we are going to start seeing that. But if things change, yes, you may need more oxygen, but not necessarily. That's why it's important to be retested also. I would say be monitored and check yourself regularly. My oxygen or canister or tank can spontaneously explode. No, it does not. You have to have some flow of oxygen and a flame or spark come together. It happens. So there are house fires, facial, body burns from oxygen, mainly in smokers, hair dryer sparks, gas stove flames, and vaping was the latest publication I saw. So you do, and petroleum products, that's just a general guideline, non-petroleum products around the face. So it is a risk, fire is a risk, but it's rare, and they have to have some combustible interaction there. Oh. This was on, I forget what the slide was. I remember the slide? I've already forgotten what it was. Oh, 4. So I'm just going to keep talking. We had combustible activity there. So 4 liters on my POC is equal to 4 liters per minute on my E-tank. And the answer is no. It might be. There was actually just a study published that did some comparison of this, the POC on pulse versus a E-tank. We find at higher levels it's not equitable. We have many patients coming into clinic on their pulse device at higher flows, and we walk them and it's not adequate, and we can switch them to the E-tank and it's adequate. So they're not equal. I shouldn't say they might be equal, but in general you can't assume that. I should be that clear. Because there are some patients that do just fine on pulse. I don't want to make that sound like you're not, but it's more typical at the lower rates. So 2, 3, 4, they may be fine. The bottom line is we really need to test you on that equipment. But you can't assume that those are equal. So not necessarily. So again, before you purchase, it is important, because I know these are not cheap. We're talking $2,000, $3,000, $4,000 for a nice POC. So before you purchase one, we really would like to have input from your clinicians to make sure that that's the right thing for you to purchase. Oxygen will make all my SOB, shortness of breath, go away. I had to define my thing there. So probably not, because your shortness of breath is not just from low oxygen levels. There can be other causes to your shortness of breath. One would be just you have a greater, what we call work to breathe. The lungs in interstitial lung disease are stiffer because in that web of alveoli and lung tissue, when you have that fibrosis or the inflammation, the lung actually wants to kind of shrink. It's trying to go in, and it takes more work to inflate it. So you may not notice that at rest, but when you walk up the stairs or go up an incline or carry something and you become more, we call it tachypnic, it's because you're having to work to breathe more. The sensation to your mind is that, boy, I'm working a lot to get that air in and out. So you may still be breathless just because of the mechanical work. And so you can be breathless and have normal oxygen. So I think it's important when patients are breathless, don't assume that your oxygen levels are low, and it can add to anxiety. So make sure you check yourself, and that'll kind of reinforce that. So other causes, so work to breathe because of stiffer lung. You may have just obstruction in the airways. Sometimes we call it traction bronchiectasis. It can actually trap some sticky mucus in there, and that can plug some airways. Muscle deconditioning, very important, because the more breathless patients get, you tend to kind of start doing less, and it can be very sneaky. You stop taking out the garbage or going to get the mail, and then you stop this, and pretty soon your quadricep muscles, you're deconditioned, and we sometimes have to say to patients, your deconditioning is worse than your lung problem. So get to a pulmonary rehab program and do some conditioning and learn some breathing techniques and overcome that. Yeah, you got to keep strong. Aerobic training. Extra body weight. If I hand someone 50 pounds, your lungs are not going to be happy. So keeping an ideal body weight helps that breathlessness. And the same goes for underweight, by the way. If you have a low muscle mass, that's also going to create burden. And anxiety and panic can really contribute to that as well. So if your saturation is 93% on 2 liters, well, then 98% on 4 must be better. More is better. No. So there's a number of reasons. First of all, your nose is not going to be happy, and we can see some pretty serious nosebleeds. People having to go to the emergency room, get cauterized. Dry, high-flow oxygen can really wreak havoc on the membrane. So make sure you're humidified and turn your oxygen down if you can when you're sitting. I know we really need a remote control, and there actually is some tech companies working on that, so that's good news. Some patients with chronic lung disease like COPD actually need to keep their oxygen within a range, not just above something, but between 88 and 92. So it is important to not just think that 98 must be better than 94. So if you're at 93% on 2 liters and over 90%, that's fine. It'll also help your tanks last longer. Oh, here we go. I have now, just don't listen to this, Dylan. I'm having an awful problem with company X, and there is nothing I can do about it. So this is what we hear all day. And I shouldn't say all day, but we hear this commonly, and then we also have problems with the DME. And it's difficult. There's a lot of communication back and forth. There's a lot of delivery, changes in prescriptions, paperwork, insurance. So if, though, after all that's resolved, and for example, you're being told that we can only give you X number of tanks, or you now need 6 liters a minute continuous flow, and this company only has POCs, and they say, we can't help you, that it can go to Medicare. And it's not an easy process. We've done it. It takes time, but there's a 1-800 number, and we really need you to call. And actually, the DMEs actually want you to call as well, because in order to get reimbursement addressed and have Medicare aware of the problems, they need to document that there is a problem. And same with our legislators. So we need you to document when you have unresolved problems. So I encourage you to call the 1-800 Medicare here. There's also an immediate advocacy process. So there is support for you, and we do want you to report problems. So, to summarize, we want you to avoid having low oxygen levels. It's hard on your heart, it's hard on your breathing, so that's number one. Learn to monitor yourself. We really want you to understand and be educated and trained on your equipment, and that's ideal, and that's in the perfect world, but that's what should happen. There's actually a Medicare guideline that says all patients must be instructed and trained on their equipment provided. So we want you to know about your equipment. And we really want you to use all the educational resources. There's lots. There was just a webinar also from the COPD Foundation. I think and that's on my list. Now, are they going to get slides? Do they get them posted? The slides, will they be posted, do you think? Yeah, okay. So I have a resource list, but there's lots of options for education on oxygen. We know that not every physician office has nurses, and they're busy, and it differs from place to place. But at least if this is the only thing you got, it would be great. And then, of course, report problems. We really want you to call Medicare.